Good afternoon. Good afternoon and welcome back. I hope you all had sumptuous lunch and you're ready for the afternoon, which starts now and will not end until sometime around midnight. So let me start with the midnight piece that we will be leaving here between 6:30 and 7 o'clock by buses. The last bus leaves at 7. We'll go for dinner. You can't miss this one. And after dinner, we will have buses bringing you back. So don't worry if you can't walk, we'll walk you back. The afternoon, we have one plenary session here, and then we have the split sessions that will be in the different rooms. I'll announce that later. I believe that you had all registered in the different groups. You're allowed to change, but it's good if we distribute equally in the 3 groups. This early afternoon, we have the topic, Globalization in the Health Sector, Business Models for New Markets. An extremely important topic because these business models are the things that we want to hear about. What works in these new markets? And we have a really, really good team here that brings in all the international experience and the hands-on in terms of business and the acumen that it requires. Let me start with Mohan, Dr. Mohan Chelapa, who's the president of Global Ventures, Johns Hopkins Medicine International. And Mohan comes in not just as a surgeon, but a world leader, knows a lot about what's happening in health practice in the US, in the UK, in Asia, and in most parts of the world, especially Middle East and Asia-Pacific region. I think you will love what he will tell you about the models that are there. And by the way, Johns Hopkins is one of the main sponsors of this conference. So thank you very, very much, Mohan. And then we have, yesterday you'll recall that we had one Dimitris too many. But today we have one Dimitris. Yeah, Dimitris is coming in. He became the CEO of Affidea in September 12. And he comes in with lots of industry experience, more than 20 years. The majority being with GE Care in Europe and other parts of the world. So here is a person then who knows the industry well, knows parts of the world where some of us have not worked about before, but bringing all that experience on the table. And then we have Frederick Rogmack. Frederick is the Chief Executive Officer of Medicover Holding. This is a leading Central European private health care company. And with this, he brings in the changes that have taken place in this part of the world, because that's something that not very many people know about in Central Europe. How have those changes happened? What models are working in those areas? And having worked in both Central and Eastern Europe, that's some input that we all require to move forward. Then we have Malvinder Singh. Malvinder Singh is, the name is probably the closest you'll have to Fortis. You probably know about Fortis, this Indian company, international company, really, that has now bludgeoned into opening facilities in Africa and everywhere. I've met you in Uganda and other places where you are. Again, give us an example on how business and health can come together to expand beyond original boundaries to be truly, truly international. He brings in his economics expertise and what is necessary to make business work. That's not enough. We have Alan Larson. Alan Larson, who is with Falk as HR manager, that's where he started. And again, here is a person who has business interests that not only are in Europe, but have gone all the way to Australia and are the very, very farthest part of the world from here. Looking at areas such as emergency care, ambulance services, and yesterday I was talking to him about the mining industry and how that's an area that's expanding all over. And we were telling him that in Africa now, where the mining industry is so big, and yet we have no regulations on how health is provided in this industry and what is required in terms of standards. So Alan will be talking to us about the business models that is had in his part of the world. But moderating is Praneet Singh, who is the managing director of Singular Gulf. And here is a real giant who brings in many years of experience, having initially trained as a mechanical engineer, but now knows the health sector more than most of us because he's made a difference in that particular area. So we have real giants here, and if they are as open as the previous speakers have been, and if they're going to be pushed as hard as I know Praneet Singh will push them, they should tell us what models work and also which ones have not worked, because I'm sure that in your very, very good CVs, you must have met some challenges and things that don't work. But we'll hear about that this afternoon. So thank you very much. Praneet, it's your turn.
Thank you. Thanks a lot for the very kind introductions. Good afternoon, everyone. This is the topic that we've been given for the panel is globalization, business models for new markets. I think if I were to think of a team of people to comment on this specific topic, I can't think of a higher quality group of panelists here. I think all the panelists here have in the past and are currently running pretty global companies. I think the range is from 12 to, I think, 45 countries, so they're very global in terms of reach. We have a good mix of, I think, people across various subsectors. So we're talking about healthcare delivery, diagnostics, oncology, consulting, you name it, we actually have primary, tertiary healthcare, both. So I think it'll be interesting to also understand some of the nuances between the subsectors in terms of how globalization is a challenge and an opportunity. Earlier in the day, you all heard Dr. Devi Shetty talk about the need for scale. I think globalization is one solution to the scale problem in healthcare. Apart from that, obviously, there are many other advantages. So obviously, companies want to become global in today's environment. So the way we're going to run the panel is I'll touch upon most of these strategic, operational challenges, opportunities, questions, and I will involve all the panelists on specific questions. And so you will, I mean, as an audience, you will get a flavor of the kinds of issues that globalization brings in, both in terms of opportunities as well as issues. And then we leave about half an hour in the end. I know the previous panel, there was a queue of people who asking the questions. So I think I didn't know that a Q&A meant for a queue of questions, actually. So we will give you enough time to ask questions. I would request that please keep the questions brief so that we can cover as many people as possible. So with that brief preamble, let me ask the first general question, and I think this is to Dr. Chelappa. So I think when we think of globalization, the big issue that as investors we always face is the issue of quality. How do you think of quality standards are they equal across markets? How do you make sure that they're similar across markets? And should you be even thinking of similar quality benchmark across markets? So given your experience with the Johns Hopkins Institute in terms of helping other institutes think about quality standards, what is your comment on this specific issue on quality?
Good afternoon, ladies and gentlemen. And Praneet, thank you so much. And I'm happy to be here. Actually, Johns Hopkins is also happy to be sponsoring the second conference of IFC, and we are very happy to be partners on this. And I think when you talk about quality, I think quality and patient safety becomes more or less as kind of a synonyms. Into that, it becomes a very important part. In US, I think it was a startling type of an revelation for us when the Institute of Medicine showed that close to about 98,000 preventable deaths were occurring due to medical errors in their study in 2000. This was equivalent to one 747 jumbo jet crashing every day. having a hospital visit and admission was even higher risk than bungee jumping. For this really made everyone sit up and then start looking at it, and then how do we address that issue? We in our institutions also had an issue with one of our patients who was involved in the clinical trials. And that made us also think about how we address that issue of patient safety and quality which is associated with that. In fact, one of the very simplest things which we did is to adopt a system of even reducing, how do we reduce the central venous line infections which come. The same study showed that about 31,000 patients were dying of venous infections, line infections during this period. For we adopted a method by which we took about 5 simple checklists: hand washing, full barrier, avoiding the femoral site, and then also sort of making sure that unnecessary catheterization is removed. With that, we were able to reduce that the incidence of infection which was occurring at a rate of 11.3 in 1,000 catheter days to 0. There was no device, there was no new technique, there was no new methodologies. It was just following the simple technique of going through the checklist of getting things done. Checklists have been used from 1930 in the aviation medicine, but then in aviation industry, but in medicine it has not been used at all to do that. By using these simple techniques, we were able to actually show that patient safety and quality can be significantly improved. Quality or patient safety doesn't reside in a person or a device or even in a facility. It is how the systems interact together and then get on to do this. It's important to make sure that physicians try to follow a method while they're doing that. Physicians are trained, not trained as a team leaders. I think most of them are trained as independent craftsmen. They want to be autonomous. They want to do good for the patients. But at the same time, they don't sort of understand that sometimes routine things can be forgotten. And therefore, using these sort of simple methods actually increases the way the quality and other systems get on to do this. Even in another study which came out in the New England Journal of Medicine, about 4,000 surgical patients, by adopting a list of about 19 items, they were able to reduce the mortality from 1.5% to 0.8%. The same way the infection, the complications were reduced from 11% to 7%. And in fact, I want to congratulate Mr. Malvinder here, because his organization was recently awarded a recognition for adopting such a model all through their systems. And then they got this one there. Congratulations to getting it. To sum up, I think what we do is we tend to bring in the systems across the border wherever we engage in different cultures and different engagements, and making sure that the physicians adopt these models and then get on to do this. Physicians don't normally it's very easy to say change a behavioral change with them. Because most of them are, independent, and then they would like to, follow the way of what they have been practicing. Instead of evidence-based medicine, it's more or less like an eminence-based medicine. I know it all. Therefore, I will do it the way I would want to do that. You have to make sure that there needs to be a constant type of, ensuring that they follow the methods. The nurses needs to be empowered to speak up whenever they found that there are some issues which are not addressed to. They need to feel that they are the part of the system which sort of get on to do this. And once you start putting them across the areas, then you would see the systems improvement, which is happening.
No, I think fair point, and I think on the specific issue of working with doctors and how difficult it is to work with doctors, I've had some personal experience myself. So we'll come back to that question to you. Alan, question for you. Now, given I know that the FAL group has done B2C, B2B, and even with the government, a lot of work across various countries. So how do you see the differences across these specific kinds of business models, B2C, B2B, and with the government? Which one is easier, which one is tougher from a globalization standpoint?
Yeah, those are very good questions. Maybe just for information, the FAL group is 109 years old. When we built, it was me, it was the family many years ago. When the company was built in the 30s in Denmark and in Scandinavia, there was no welfare state as the Nordic welfare states are today. So basically what was built on a business-to-consumer business model. And actually that business model has survived in other types of services through all those years. So what we have today is a group that works on government contracting, business to business, business to insurance companies, not least pension providers, and of course, as you say, business to consumers. And I think maybe the fact that we have those different business models in the group has made it possible for us to quadruple, which we have done from 2004 until now. So we've been quite successful in rolling out our services across a number of nations, and we're now in 47 nations. We focus on pre-hospital care, primary care, and we are moving into secondary care. I think that the ability to work with these different business models and take them into new environments, combined with the ability to find the right the communities where you can have the necessary level of trust and transparency. Those are maybe the two, or at least two of the major points when you want to roll out your business model or provide your services. I will be very discreet. However, in a number of countries, we do not dare contract with governments. And I'm not going to mention any countries, but we do not dare contract with governments. So the fact of the matter is that the only way that we can provide the services that we command to these countries is through alternative business models. Obviously in Europe, most of Europe, you can provide the services funded by the welfare states, and you can be a provider based on tendering. In many, many countries in the world, this is not possible. So we have to find another way in. And we've been able to develop models, for instance, in Latin America, based on subscriptions, prepayment programs, plans that was mentioned earlier today, actually plans based on a capitation model. So we don't really, except when we contract with insurance companies, we don't have a stop loss. Basically, you sign up for a coverage, and then we provide that coverage, and we also cover the actuarial risk. So that's how we found that in at least the Latin American markets where we've been most successful compared to other emerging markets, this business model going directly to the consumer has worked. We then combine that with businesses where there's a willingness to actually pay, to tap into the business-to-business environment. They will then either disperse the service through a deduction of the paycheck, or they will actually, in some cases, actually pay directly.
Right.
So that's what we've been doing. I think another very central item in how you can take, we are a developed nation provider into emerging markets, is to build strongly on partnerships. We have to be very humble. If you've seen one healthcare system in the world, you've seen one. The diversity of the systems is simply unfathomable, and you have to tap into this. You have to find ways into the different systems, and the way we've been doing that is to work with partners. It is really an alternative way, I guess you can say, to control complexity. Normally you would control complexity by reporting, by structures and so on. But if you have a dispersity of business models, then obviously you need to find another way to control. And we've been able to do it through our strong partnerships. Do I have 2 more minutes?
Sure.
Yeah. I want to just emphasize that We've been doing this based on being a foundation and a family-owned business. And I think that if you want to take these models out in the world, you have to have, as was said in The Economist a couple of weeks ago in the special report on family businesses, you have to have strategic patience. If you're there for the fast buck, if you're there for short term, it's not going to work for you. You have to have the long-term strategic patience to build this business, and at least with the kind of ownership that we have, that has proved to be possible. Maybe I could round it up by saying one of the things that we search for when we go out, except of course, we think that if you can do it, it's an obligation to provide or bring out the services into the world. Obviously, we're also for profit driven. We have our ambitions in terms of getting a return of what we do. But there's an element that I would like to highlight for you that we are looking for as well. It is really to sort of be disrupted at a distance, I guess you could say. A couple of times today, the word, I think it was translated into Uberification. That's what we call it. Maybe we should just call it to be Uberized. But anyway, that risk is there for many providers in the mature world. So when we go out, we also have an ambition at some point to be disrupted at a distance, so to say. And if you have a portfolio in Europe or in the US, and you go out and provide these services and you can find alternative business models, then you can actually learn that before you implement them in your home yard, so to say.
No, great. Thanks a lot. So I think that last comment on longer timeframes was probably addressed towards me, I think, because I'm the private equity guy here.
I didn't say that.
No, I think it's a valid point. And when we think about investing in these markets with a 5 to 7 year time frame, you start thinking you would do things probably differently when you have a 15-year time frame, and maybe that's the better time frame. And I think one thing which always worries me when I look at companies which are globalizing is how do they manage different price points? Especially from companies which are in Europe or the US, they want to come to India and they look at the test, the cost of a test or normal blood test here, it is 1/10 or 1/20th of what you would do in the US, right? So how do you manage these different price points? I think maybe this is a question for Dimitris, given your diagnostic business. How do you think about, I know that you're broadly in the European countries, but even there, I'm sure there would be differences in price points and affordability issues. How do you think about those issues?
Correct. First, let me say that we are both in Eastern Europe, that there are still emerging countries, right. Even we are in this country, and you see very different price points than to Western Europe. But I think I would like to echo first Professor Sethi in the morning that said that this question is not only for the emerging markets, but it's actually for all the world. I'm sure, Pranit, you will agree with me that every policy maker today in the Western world try to provide more and better access to patients. At the same time, they try to contain their costs that they are soaring in every budget of every state in Western Europe. But before responding to the question, I would like maybe in 2 sentences to explain a bit what Affidea is doing just for the benefit of the audience. As we have changed our name actually in the beginning of this year, and maybe many people they are not aware of us. So Affidea was called Euromedic until January this year, and we are one of the largest investors and operators of medical imaging, diagnostic imaging, and cancer care services in Europe. And we have a vast experience in the PPP related health services, as we are active in most of the Eastern European countries, as well as in the Western European world. It's a sizable operation. We have 150 centers, 153 centers in 14 countries. We have more than 750 imaging modalities, 4,500 people, and we serve more than 4 million patients annually. Now, from this experience and from our Eastern European experience, I would like to say that, again, I would like to echo what Professor Sethi said in the morning, and maybe I will echo to what Mohan just said now. In order to be able to really provide high-quality care in a smaller margin, you have to be able to drive care standardization in evidence-based medicine, and also develop scale. So this is the way you can build efficiency and also secure through the standardization a high level of quality and a standardized, homogeneous level of quality and patient safety among your countries, your regions you operate. Now, obviously, we need to reinvent, revisit all of us our operating models, and I'm sure that IT is playing a key role on that, and I'm sure we're going to find a chance to discuss that later. And in our case, CapEx utilization plays a key role as we are in a capital-intensive business. I think there's a very big conversation today everywhere around this subject, as in the emerging markets, they try to provide better coverage. In the Western world, they try to, for the same amount of money, to serve more patients. In short, I can tell you an example of ours. We claim fame that we can indeed provide high quality, standardized medical outcomes at a lower unit cost. And an example on the qualities that I just said before is that we have been able to deploy the last 5-7 years an internal know-how of lean management, have a lean management experience that allows us to optimize our processes in our centers. So we manage complexity actually in a very nice way. We have a great asset management. We have a great asset utilization, and we borrow this experience from the aviation industry. I remember Max, he was in our conference some years ago, and he said, if you are in diagnostic business, look at Ryanair. And actually, when you can provide a huge number of MRIs per day, then you can allow yourself to have a good margin even at a lower price point. And obviously, we use IT and big data. As what we see in our industry currently, there's a complete separation between the image acquisition and the image interpretation. It doesn't matter where you are having the MRI and who is going to read the MRI from which region in the globe. And this allows both efficiencies, because you can go to the medical doctor and commit a specific number of examinations to interpret per day, so he can do that for a better fee for you. It allows higher quality in the sense that we provide knowledge in remote places. It allows better patient experience, as patients can access their image or their examinations from everywhere. So in short, if I will sum up, my answer is that you need to develop skills in managing your asset better. You need to be able to develop operational know-how to remove waste from your daily operations so you can staff better. And obviously, you need to develop scale, because this is the only way to have the right resources to keep on reinventing your business model going forward.
Right. Oh, great, thanks. Malvinder, you personally drove a lot of M&A in India, Southeast Asia. You bought a lot of businesses. You also did greenfield. You also divested businesses. In some ways, refocused a bit on India in terms of healthcare delivery. So what has been the, and this is a very general question, but what has been the broad learning in that entire few years in terms of either acquiring, integrating, and then divesting businesses?
I think clearly it's been a very exciting journey for us as we, from India, went international, where 50% of our business was international. And then over a few years, we've again refocused to be 100% India-centric because of the huge opportunity that India has. But I think on the one side was the business models and structures, but I think what comes across very visibly is that in many of the developing markets that we'd entered, the kind of teamwork that the leading doctors have, the way they talk, the way they address a patient, and the patient centricity is, I think, far more than what it is today in emerging markets. The other component that was extremely visible was the empowerment and the decision-making and the engagement of the nurses when compared to the developed and emerging markets. And I think that level of engagement and empowerment and the way they treat patients and the families is at a much, much higher level than it is in many emerging markets, including in India. So I think those two came across as very significant learnings for companies like ours coming from emerging markets. At the same point in time, if you look at the strengths of emerging markets like we have in India, what comes out very, very visibly, which I think is an opportunity for, hospital businesses like from India going into other emerging markets, is the quality of care that we're able to provide in India with the efficiency, the productivity, and the price point at which it's done in India is, I think, remarkable compared to many other countries, including in developed markets. And therefore, if you're able to look at the turnaround times that we have in India, I think we believe they are far, far superior than what's available elsewhere. So I think those are very clear, distinct differences that came, and therefore opportunities as you're able to leverage these capabilities across different markets. But I think one of the stumbling blocks as you look at addressing opportunities in healthcare delivery across different markets is really from a regulatory perspective in terms of mobility of talent, medical talent. And it's not easy to be able to take doctors from different countries in terms of having them practice and do surgeries or provide treatment and consultancies internationally. And I think that's clearly one big aspect. If as a community we're able to address that, I think the scope and opportunity of leveraging capability at the best price point with the best quality would be able to have patients across the world, or at least in multiple markets, get that benefit, which today in some ways is restricted, and then you've got pockets of differential pricing that are there from market to market. So India clearly is amongst the most cheapest healthcare service providers in the world, but at the quality at which you get here, it's truly world-class. And if you look at a comparison in Singapore, you'll probably pay anywhere between 5x and 10x for the same service. And I think there clearly lies that opportunity. But one of the learnings that we had when we had made investments internationally, including when we acquired the Parkway business from TPG, which we eventually sold to Khazanah, was their business structuring where they had a REIT and therefore made the main hospital entity asset light, which is what we adopted at Fortis, creating a business trust, and the first one out of India listed in Singapore, which really made our balance sheet much lighter and kept us asset light. So we can today very easily double our capacity of beds from 4,000 to 8,000 beds with very minimum capex. And that will give us a huge scale in terms of going beyond the 55 facilities that we have in India to be able to serve a much larger part of the market.
Great, thanks. Frederick, we haven't touched upon insurance, and I think your company does insurance as well as healthcare delivery with insurance. So as you go across different countries and markets, obviously the level of insurance coverage is very different, and even the pricing could be very different. How has that impacted your overall globalization program, and how do you see, is that a challenge if insurance covers are low? Is it an opportunity? I mean, how do you see that as a business?
Yeah, thank you. Perhaps also just to start with, for the benefit of most of you that probably don't know very much about Medicover, so we're slightly younger than our 109-year-old Danish neighbor. So we are Swedish origin and roots, and we are turning 20 this year. We do two things really. On the one hand, which I will talk more about, we have an integrated insurance provider model. So we run a network of some 85 medical facilities across most of Eastern Europe, where Poland is the largest, and around that we wrap around our own insurance coverage and subscription, depending on the regulatory environment. And the other half of what we do is we run a regional laboratory pathology business in 14 countries now. And overall we are 11,000 people employed, of which 9.5 something are medical professionals, all from our local economies. So I think to address the question, first point I think is a point that's been made many times before here today. Each country is unique. One of the big learnings we did, we thought, or rather I thought I should say, that you could apply much more of a sort of copy-paste model when we started out, which did not work. So we have entered some market that we subsequently have exited because that sort of insurance subscription model did not work for a number of reasons I can comment on later. I think also we have seen that the large global insurance companies that either were in those markets or subsequently have entered, they have also struggled with the sort of a traditional indemnity standalone health insurance model. I would say less so for traditional cost containment reasons, more so for quality of care and accessibility, and even to the point that I would argue that still today, I think the integrated model that we and others represent is still winning ground on the standalone indemnity insurers. Again, not because of cost or price reasons, but because of customer service and accessibility. That is something that is probably likely to change over time, but in none of the markets where we operate have we yet seen that starting to happen. I think something we all struggle with is very different than 10 years ago. 10 years ago, we always had an abundance of good quality medical people to recruit from, so it was a tremendous amount of good people to hire and bring into our services. I would argue that today is our, and I'm sure our competition's as well, largest impediment to growth, that the pool of qualified medical people is severely diminished to recruit from. Right. And I think that addresses the insurers as much as providers. So I think the summary of my answer is each country has presented its unique challenges. Clearly, in the East European setting, Poland has stood out and still stand out as attracting most interest because of a large economy, because of a, I would say, rather vibrant private sector. That is not to say that other countries aren't interested. When you look at where have the large insurers brought their attention, I would say Poland, in terms of the countries where we operate, have stood out.
Mm-hmm. So healthcare is basically delivered by doctors and nurses and the paramedics. That's what we were discussing in the morning as well. And I think Dr. Chillappa and Malvinder, both of you kind of referred to the importance of doctors and teamwork and doctor-nurses teamwork. I think those were the interesting aspects of globalization. So, Dr. Chillappa, a question for you. I mean, have you seen doctors behave fundamentally differently in terms of how they do the treatment and think about protocols in various markets? And how difficult has it been to get them to agree on a protocol or agree on something which is impacting quality? Or is it less of a challenge? And then maybe go on to nurses as well. It's a very micro point, but I think it's important from an operational standpoint.
Absolutely. Especially for us as an institution which was based in Baltimore in the US, and then when we start spreading our wings outside and then start engaging in international projects, one of the things which really was a big concern for us is how do we ensure that the clinical quality which is being delivered by the physicians on the projects and all the facilities in which we are engaged on is similar to what we would provide back home into this country to do this. There is a certain amount of variability always in terms of this competency when you go out, because it's difficult to get a uniform type of a standardization in different parts of the world to do that. But then there are certain amount of competencies which are being assessed, which makes one being comfortable to say that, look, fine, there will be a certain standards which will be met up with when the physicians are employed on that. You look for three things whenever the physicians are engaged. One is the knowledge, second is the attitude, and third is the skill sets. These are the three things which needs to get on to do this. At one point in time, you can look at it in terms of the big buzzword is how do we create cultural competence, among the groups which are doing that level. But then It's very difficult now because you always meet with diverse physician community in different parts of the world who are working together. And it's therefore, it is becoming now when you start introducing, as Malvinder was mentioning, the patient centricity into that, and then this cultural competence and all becomes second, because everyone starts to think that, look, fine, how do I deliver the best to the patient, which we want to do that, get on to do that. Having said that, most of the today medicine that's being practiced in the sense that it's becoming from an art to more like a science now, in the sense a large part of it is thanks to engineers, processes, and other things there to get on to do. You can sort of distill many things into a way of steps and how it is there. And if there is any deviation from that, it can actually even picked up by the IT system which you have, which doesn't allow you to go beyond your protocols to do that one. There is a lot of consumerism which is coming in that same, and the patient, themselves have done a lot of work on this. And then they are aware of what are the protocols and how it is getting on to do. Well, we tend to bring in as much as possible, at least care pathways, which are helpful for the physicians. But at the end of the day, you can't dictate the physicians to do everything just by the book. It's not possible to do that because there is certainly an element which is necessary to give the latitude to the physicians to decide what he wants to do to the best of the patients to do. For you have to give that latitude, but at the same time make sure, but there is certain ground rules and certain framework which is sort of get on to do this. To answer your question, is it a challenge? Yes, it's a challenge, but it's a challenge which is manageable because it's becoming less and less obvious because, thanks to the, spread of information, it's becoming, someone who is doing something in Boston and someone doing it in, say, Bangalore. There is not very much of a difference in terms of the practice methodologies which are being concerned. It is just the question of bringing in the culture of teamwork, the culture of empowerment of the people, the involvement of the patient in the decision-making process. And those are the things which needs to be done into the physicians community so that you can elevate the level of,
So you mentioned IT, and I think interesting take. Maybe I'm going to introduce we've already introduced Uberization, which is the one word which we learned in the morning, and now I think disruptive is the other word which seems to be the fashion of the day. So IT, and I think this is a question for Dimitris and Malvinder both. Both of you must have seen IT as an enabler and also, I guess, an issue in terms of globalization. So how disruptive can IT be from a globalization standpoint? Maybe a question for Malvinder first.
I think clearly IT is a huge enabler.
Okay.
It's a huge enabler, but I think there's a huge amount of reluctance, as I've seen it within the healthcare fraternity, to be IT empowered and to use IT as a tool of efficiency and productivity and dissemination and connecting with the patients and future consumers. And therefore, therein lies the opportunity in terms of being able to leverage it, given where we are. I think, as we see across many other industries and sectors, where technology enables consumers options, choices, decisions, and being able to drive where they want to take their business and how they want to engage. In the healthcare space, clearly, as we are seeing what's happening around us on a daily basis, this is a trend that's there to stay. It will be disruptive, but in those disruptions, we'll have to evolve and fine-tune our business models to take advantage of this rather than be concerned or worried and threatened around IT. But clearly, over the next 3 to 5 years, the way healthcare gets delivered, the way consumers interact with health systems in terms of staying healthy, in terms of being engaged through communities for having chronic care and having healthcare delivered beyond the walls of hospitals and facilities and healthcare service centers, but more at home, is a change that's going to happen which will be driven by technology. And I think that's something as an industry we need to accept and use that to make sure we are evolving and staying with times rather than trying to fight it. But as we do that, I think it's also important internally to make sure that doctors and the medical community is reasonably well attuned to be able to use this rather than trying to resist it, which is what happens many a times. And I think those are some of the things that we would need to continuously work at. It is a journey, but it's a journey for all of us to work through. But to your question about what disruption and how it will evolve and change, over a period of time, eventually, no matter where you are in the world, you will, through technology, be able to have access to whatever medical advice you need around the world. And therefore, world, from a healthcare perspective, will become a far more flatter space. It may not become totally flat because of healthcare regulations and who's going to pay for it. And therefore, the payer aspect here becomes important because it's very different in emerging markets, very different in Europe, and very different in America. But keeping one or two of those critical aspects out, there will be a far more flatter space that will evolve. Dimitris, you want to?
Let me be maybe the fifth to repeat the Globalization that Sakita early on introduced to this meeting, and say that in our industry, especially in medical imaging, but also in radiation oncology, Uberization of healthcare is here now. We do use IT in a disruptive manner to connect modalities, radiologists and patients, and also standardize further our care delivery. And because this sounds great, but what does it mean practically? Let me try to explain that with an example that everybody will understand. So if today we have a nice Irish operation, and we have many nice centres in Dublin, in Kilkenny, in Cork, and in many other places in Ireland. So if you are a Kilkenny patient, and today you wish to have an MRI, you enter to euromedic.ie. Ireland is not rebranded yet, but soon it will be affidea.ie. And then on the right-hand side, you have a booking engine, and you actually book a slot in our radiology information system. Then you come into our center, and there is no radiologist. Because in Ireland, there's a huge shortage of radiologists. There are actually 188 guys that most of them they work for public sector, and it's quite difficult to find. And further on, they had created some entry barriers, and other EU radiologists cannot easily enter Ireland. So you have a GP that ensures your safety. You have a paperless process, because everything is practically already put your demographics through the Affidea Euromedic web. You have your MRI, and instantly your MRI is stored in our pan-European cloud, except Switzerland for some regulations, where we have on top of your MRI, the last 5 years stored 1.2 petabyte of images, which is a strong number, a big number with many zeros, actually, if you remember from school. And then this MRI is diverted to the person that has the right skill in Dublin, and it is being interpreted in Dublin in a hub that every radiologist sit. And then after the MRI is interpreted through voice recognition, then you receive an email with a link with your diagnosis and your full image set. Then, if you trust better Johns Hopkins, which might be the case, and you want to send it to a high-end consultant for second diagnosis, you just forward your email, and one of the staff of Mohan can have access to this MRI. This is today, and this again allows, as I said before, to provide skills in remote places. Today, if you have acoustic temporal bone image examination with an MRI in Hania, in Crete, south of Greece, in an island, you may have the examination, but this will be interpreted from Piraeus, from a doctor who is skilled in this specific anatomic area. And again, because people are getting used to, I will give you the number that 20% of MRIs today in Ireland are booked through the web. So practically, in imaging, we are living what the aviation industry lived a few years, that each check-in was something like a luxury, and now everybody's frustrated if he has to go and wait to the booth. Obviously, different languages has to enter to this scheme, and we have been the one that we work close with Nuance and other producers to have voice recognition in exotic type of languages like Lithuanian, Polish, Greek. There was no any kind of thing like this before our presence in the market, but we think that this is where the future will. This is what we're going to see in the future. I want to say that, on the other hand, in order to be able to provide proper radiology, you have to ensure that the same protocols are used no matter where the MRI is conducted. Because if you use a different T2 weighted protocol for your knee MRI in a place, or if the local technician will decide how the MRI must be conducted, nobody can interpret that remotely, which again, it's a big argument while care standardization will prevail in the future. Maybe a second example that I would like to share with the audience, and again with an example, is how we try to standardize care, and maybe how we also are able to manage change in places that you have objections from clinicians from this new era. One of the things that we are doing successfully in the last 3 years is that we are standardizing the CT protocols driven from the dose our patients get when they have a CT. So today, if you go to a very nice trust in the British National Health Service that they provide a high-quality care delivery, the amount of dose you are going to receive is just related to the personal understanding of the protocols of the medical doctor and his personal wish to see a better and a clearer medical image. Nobody measures what is the incremental information I will receive from a CT scan image for the dose that patient gets. So what we do is that we have all our CT scans connected. Actually, the 80% of our CT scans connected, because some of them, they are still in process. And we received the last 3 years the dose. In real time, whichever examination is above the threshold we have set, there's an action locally, in country level, and from our chief medical physicist in the group level. Then, based on the data we receive, we're able to standardize CT protocols in the future, ensuring the ALARA notion, which is you have to give a dose as low as reasonable, achievable for a high-end image quality. And then this does not only allow us, Pranit, to standardize dose and standardize the protocol of CT wherever you receive a CT scan in our centers in the countries we operate, but also allow us to go to our successful Western European doctors, like the example of Switzerland, and we say, dear doctor, obviously, you come from a very successful country, you had premium medication, and you have the best equipment, but facts say, data say, that you give 10% more dose than your colleagues in Switzerland or your colleagues in Romania.
So you can standardize the protocols.
And then it's not about who said what is the right protocol, it's about what facts is giving you as a feedback. And I think it has been pretty successful in what we do. Obviously, your challenge is bigger, Mohan, because we have a subset of care delivery which we try to standardize to the maximum we can.
No, obviously, I think there'll be obviously sub-sectors which will be more amenable to IT, and there will be, I mean, the pure healthcare delivery is always the toughest. The primary healthcare delivery is also pretty tough. So maybe go on to my last question. I know that we're running short on time, and this question is jointly to Alan and Frederick. I mean, you obviously go in with a view of you have a business model in mind, you go in with a view of building that business model in a local geography or a new country. What is the impact on that ecosystem? And if you could just comment on whether that fundamentally had impact on beneficial, hopefully, in terms of how that ecosystem developed. For example, you did primary clinics in Latin America now, or similarly, if you do primary clinics in India, those businesses are fairly unorganized today. I mean, when you try to organize them, obviously, it will have some impact on tertiary care, it will have some impact on diagnostics, etc. So just comment on how do you hopefully beneficially disturb the local ecosystem and what happens really, and how do you manage that?
Yeah, I would like to comment on that. But before, if I can, sorry, I was so quiet. Maybe just a couple of remarks on the business models and the roles of the different players, and then get to your point. I think one thing that we haven't really addressed in this discussion that I would like to put up, because I noticed there's quite a few private equity guys around, right? I think we need to understand that there's a special role for local business people, and in this case, I will then say business people equals private equity, to take a special role. If you look at somebody like us, we are a very old company. We've been around for a long time. We have our rules and procedures. We have our, things that we can do and we cannot do. If we are to interact with a given local community, there are structures that need to be followed. There are models that cannot be compromised. And in order to bring some of these communities or services in these communities to that level, you need to have actors locally that take care of that. You talked about fragmentation. In a number of those markets, the provision, at least when you look at primary health care, and indeed also the services that we provide in some markets in terms of EMS service, it is completely fragmented and it is not organized. And obviously, we would be happy to take a role in organizing that, setting it, bringing it to the level that it should internationally. But it needs to be at a certain level, and I think you all know what I mean, in order for us to interact. And in that position, we need to have local business people, private equity, to take a role. If you don't understand what I mean, then let's talk about it afterwards. In order to create a structure where we can go in and make a difference and bring, or at least assist in bringing international standards to that ecosystem. I think there's another way when you look at how healthcare provided by private providers can be brought into communities, and that's through the public-private partnerships. We have been offered public-private partnerships in some countries. We've had to shy away from it. One of the ways to deal with that is to work with institutions like, indeed, IFC or other similar institutions, because they will give you, if you allow me to put it like this, a level of protection. But obviously, if you go into these structures, you need to have an institutionalized system where you can actually interact. And for me, when I look at the countries that we could potentially want to go into, these issues are huge, and they have to be dealt with. And obviously, the best way to deal with it would be to have a regulator do it. But in many cases, that is not an option. And then you need to find the other ways that I've described. If you look at, and then I guess finally, I get to answer your question, really. If you look at the impact that we can have, or providers can have, when you go into providing, or you provide the services locally, obviously, if you don't believe you can improve the segment that you're in our case, primary healthcare, then you shouldn't do it. That is part of what we are there for, and that is part of what we should do. And in order to bring practices and structure or when we bring practices and structure the areas that we enter into, then obviously we will participate in increasing healthcare. We provide the services on a for-profit basis. We target the emerging middle classes. We hope and believe there will be a trickle-down effect based on that. At least we can assure that there will be, at that level, a provider that can hopefully in the future be something that can be copied for for providers for other segments of the community.
Thank you. Very useful. Frederick?
Yeah, I'll give you two quick specific examples of where I think we have at least had a little bit of an impact on the ecosystem. One is to do connect back to the technology discussion. Now, across several of the lab markets where we are in the eastern part of Europe, we employ a lot of histopathologists. And as many of you know, it's a chronic shortage of histopathologists across Western Europe. And I think that's a very interesting that we're involved in right now with a technology project together with some partners where we hopefully within, possibly even within this year, we'll be able to connect our histopathologists to public payors in the West European countries that 5-10 years ago would not just have been on the surface to even discuss that. That's happening today because there's no other way to solve the shortage in Western Europe. So I think that's an interesting specific example. The second I just want to also mention is in Ukraine, where we started a lab business in 2007, so that's 7 years ago. I don't know if we have any Ukrainians in the room, but the state of the public healthcare system in Ukraine wasn't good to start with, and it certainly hasn't gotten any better through the financial crisis. And we have, or rather my local colleagues have invented, if I can use that word, a B2C type of model that I don't think we have seen elsewhere anyway. So I think now we have a network of some 250, 300 BDP locations where actually customers come straight into us. So actually it's the lab that's the brand name. It's not the hospital or the clinic, but the customer actually knows the lab, which is something we experimented with. And the interesting thing with this now, with the obviously very significant crisis Ukraine is going through financially and from various matters, it's interesting. We have seen no impact whatsoever on the local volume and local currency activity in our labs business, which is, you can say, well, that's nice to say, but I bring this up as an illustration of the fact that a very, very vital and required activity in the healthcare system, if you just make it available and it's priced at a way so people can afford it, it even lasts through the sort of current turmoil.
Yeah, no, very, very interesting. So I hope everyone's got we try to cover as much as we could in terms of operations, strategy, challenges, opportunities, disruptive or potentially disruptive things that you could do from a globalization standpoint. We would now open it up for questions or comments from the audience. If you could announce who you are and ask specific questions, please. And if I may request, please keep the questions really brief, because then we can spend time answering them. If the question is too long, it takes too much time. Yes, please.
Okay. I'm Maureen Lewis from Georgetown University. One of the things I found interesting, you started to touch on, and that was nurses. In North America, they're increasingly taking over a lot of functions that doctors once did. Working in teams implies that they're team members. They tend to run hospitals. What kind of resistance do you find in terms of changing that function? One, two, upgrading their functions, because they're quite different in different countries. But I think it's a sort of a key part of the healthcare delivery system in all countries. But none of you really mentioned it yet, and I'm sort of interested how that plays out in different parts of the world that you represent. Thanks.
Okay. Well, thanks. Great question, actually. So on nurses, anyone wants to take that question? Dr. Chilappa? Yeah?
Sure. It's good that this question came, because I was actually planning to give it as if as a comment. There is a significant change, a paradigm shift, which is happening in the healthcare industry. The hospitals and the specialists used to be the heroes of providing the care and then sort of getting out to do this. Those things are changing now. The hospitals and the specialists are going to be people who would perform certain procedures, and they would perform that procedures very efficiently. Therefore, there will be more or less like process people. If someone wants to have a cardiac catheterization and then sort of an intervention and then putting up a stent, it'll be sent to the specialist. He will do that procedure, and that's it. The importance is going to come to the team which is outside of the hospital, which is obviously needs to be a care coordinator, a primary care physician, and the whole team of the people who are actually the owners of the patient. And they send it to this particular specialist for this cardiac problem. They send it to this nephrologist for a renal problem, and that wants to do that. For that brings a lot of importance to the nurses and also the care team which is coming there, and they are going to be the owners of the patients as they come along. And this is also the way in which the cost of providing care can be considerably brought down. For many of the institutions today, I mean, you are right in the sense that in North America, I think the nurses are more empowered. They are, we use a lot of physician extenders. The nurses are doing procedures, which are coming on to do this. In the rest of the world, it has not come into the market because the licensing issues, now we are doing a project in Saudi Arabia, and then we are finding that we needed to get some special permissions to actually get the nurses to be performing certain procedures to do. But that's the way to go, and then it is going to happen, both by cost pressures and also the patient experience. The patient would feel much more comfortable. A nurse which is talking to them and get them through that rather than speaking to a particular specialist for a short period of time.
Yep. No, thanks. Good question.
I just want to add one thing. Since, firstly, I'm glad it's quite the first question was the nurses, but today's also Nurse Day. So I think clearly in India, for us, it is a journey compared to the West, especially the US and even in Singapore when you look at the comparison of what happens in terms of the active engagement and the role of nurses. I think in India, it's certainly evolving and moving where the nurses will continue to take on more. But the biggest challenge that we actually face in a market like ours is most of the better nurses go to the Middle East, Europe, and then the US. So the attrition rate of nurses is so high, and the price points that they get in the US are so high that very few of them actually want to stay in India. And therefore, it's a constant churn of training, retraining, getting new people. And by the time you get somewhere, you actually go down and then again come back. And therefore, the importance of systems is critical for us. But when you lose that good talent, it does take a toll. And therefore, it takes longer.
Sure. Question from the middle microphone. Yeah.
Thank you. Thank you. My name is Josh Landy. I'm an internist and a critical care specialist from Canada. I'm also the co-founder of a healthcare startup called Figure One. I've heard a lot today about disruption and the Uberization of healthcare. And from a physician's perspective, and one from working at a startup as well, I see a lot of physicians and other people working to innovate in the healthcare space, people who are looking to develop new solutions and present them often to healthcare organizations. And what I've been experiencing myself and as well hearing from other people is that they will often present ideas or concepts or tools that they'd like to use only to have a multi-layered administrative body say no, or we need to use specific rules, or it needs to be adapted or changed, and the change in these organizations needs to come from the top down in the trickle-down effect, like you mentioned. In Uber's case, they did exactly the opposite. And that's what disruption was essentially meant to affect, is the disruption of a very large organization, which means that large organizations aren't the ones necessarily, or almost ever, doing the disrupting. And Uber has been fighting long and heavy, gritty, dirty battles in a lot of situations with large organizations. So I wonder if it really is Uberization that large organizations want, but I would love to hear your thoughts on how we can accomplish these tools or move forward, really.
So is that a question or a comment?
I would like, my question is, how do you perceive that large healthcare organizations can deliver truly disruptive technologies in the age and with the current climate of innovation in healthcare?
So everyone wants to answer that. Maybe Alan, go.
Yeah, at least I would like to, I'm glad you finally, came with it as a question, because I think it's extremely interesting. I think the short answer is it's not going to happen in large organizations. Yeah. It's simply not going to happen. So the idea of Uberizing your own organization is not going to work. And if I look at what we have in Europe, and the corporate, it'll never work. In a way, and I think that's very important as well, that is good for large corporations because, if you work within healthcare, you want a protected environment, you contract with governments, it's very stable. That's good news. However, if you want to do this, and I think it needs to be done, obviously, then you have to get into other markets. And you have to get into a relation where the relation is between you as a provider and the client. And hence I talked about the business to consumer relation earlier. If it goes through a dispersed system where it's through a Medicare, Medicaid, or commercial insurance, it won't work, is my view on this.
Yeah, Dimitris, briefly.
I will be very brief. I would like to disagree. I think that it will work for the following reason, and the reason is called tariffs. 3 years ago, the Irish MRI tariff, and I'm sorry for bringing always MRI, it was €350. Now it's as low as 97. I mean, and in this environment, if you want to make a return, if you want to pay medical doctors appropriately, you need to think differently what you're doing. And I do think that Uberization will go forward, not just in terms of IT. Maybe we can rename that we will keep improving and reinventing what we do. In order to be successful, though, it has to be a clear message from the management, and the management has to allow that a continuous improvement culture to be distilled in the organization. And allow me, I will take 1 minute more to say just one example. I mentioned before about a major initiative of ours that is called Lean Management. It's about the Kaizen methodology. And people think it's also this nice American expression, lean is mean, that lean management is something that a magic tools of private equity to cost out everything and they have a lean, low-quality organization. No. Lean management is a process that you put the patient in the middle and you try to think how you should reinvent your process in order to make it better, more efficient, safer, high quality for the patient. Cost out might be a consequence, but it's not the major goal. And the way we do it, and we are in the 6th and the 7th year of experience right now, is that we put in the same room. I mean, there are many methodologies. I mean, the prevailing in our organization is the value stream mapping. When we put in the same room medical doctors, technicians, administration staff, and we ask them, first of all, to map what they're doing. The first thing we see is that everybody has a totally different perception on what is happening daily in the plan, in the center. Then they are the ones that they have to come and say, this is how best we should do that, so you don't bother my job when I'm interpreting my example. I'm sorry about that. I don't bother your job where you are managing the scheduling and so on and so forth. And then guess what? The first thing is that you are designing very efficient processes that they are coming bottom up. But most importantly is that we speak the same language and we are building a continuous improvement quality down to the last center in Solier, in Crete, in Évora, north, south, west. So I think that continuous improvement has a chance. It's a must, as Professor Sethi said. If you don't have money, you have brains. I think that as tariff will go south in Western Europe, more and more innovative models will come to improve care further.
So if I may,
Uber is one
if I may interrupt, sorry.
sorry.
I think Frederick also wants to make a comment, but I can tell you from an investor standpoint, and I have no axe to grind. I don't run a big business anymore, so I need not be defensive about innovation. But I do see that the kind of opportunities that we see from an investment standpoint in existing businesses which have scaled to a certain size, I think there is, and I think you have a point here, and we have to all think this through. I think there is a level of, no, I won't say laziness, but some thought that healthcare is a big opportunity. There's so many patients going unserved. So even if you do what you're doing with minor modifications, you keep on growing at 20%, and that's what they need the money for. While most of the disruptive stuff that we've seen if you look at the venture, we do venture investing also in China or in India, all of that has come from the smaller players or completely new players. And so be it. I think there's nothing wrong with that, actually. So I think what the existing businesses have to worry about is how quickly can they incorporate a disruption and actually use that in their business.
I think I'll just address it a little differently. Sorry. Big businesses, especially when they're successful, will do incremental change because there's always inertia and resistance to change because of the uncertainty that it brings in and because they believe as a management system and structure that, look, if it's worked for us and we succeeded, it's going to move ahead and succeed, but that never happens. There are gaps, there are opportunities, and it's always better to be disruptive from the outside with smaller teams who don't have the baggage, who don't have the risks of failure, and will continue to move on and do stuff. And therefore, as an entrepreneur, for you personally, I believe it's a great opportunity. But as much as exciting and as an opportunity it may be, there will be challenges and pains that you will need to be comfortable to shoulder it and walk through that journey. Many will succeed and some won't. But wish you all the best, and please keep it small, keep it innovative. Think of all the things the big guys don't think of and make it happen, because as long as you hit the gap in the need in the market, you will be successful.
Frederick, you want to quickly comment?
The quick comment, I think that's has been said now, but I was going to say that I think, commercial pressure drives innovation. It's big or small, and I think, senior management in our type of organizations, our responsibility is to try and, because these reimbursement systems, they're all very different. So I see, in some countries, we're rather insulated, and you can lean back and be rather comfortable. In other countries, it's completely opposite. So I think if it's one thing that's management responsibility is to try and make sure that we take away that level of insulation, if you wish, and let that commercial pressure, which exists in many places, drive innovation throughout an organization. I mentioned the previous was said that Kaiser Permanente had put 40% of their interactions on. Now we. One of our biggest commercial pressures, and I think that's never going to change, is the utilization in an integrated model. People just use it more and more. So over the past 5 years, we've been able to shift about a third of our interactions onto. So it's less than Kaiser, but still it's a very significant amount of visits that's gone on the electronic interface.
Yeah. We'll take, thanks a lot for a very interesting question or a comment. I think we spent a lot of time here. Question from here,
right.
Please.
Olumide Okola, Nigeria. The recent Ebola viral disease outbreak in West Africa, and still ongoing in certain parts of the subcontinent, is perhaps opening up a vista of opportunities. Now you have governments wanting to work together, which wasn't the case before. So I would like to push to the panel that will regulatory harmonization of sort help in investment decisions, because this is some of the things we do, and would like to get some feedback whether that will help. I mean, you have a doctor who probably can't cross the border from Kenya to Uganda to go work. Devi Shetty has operated on thousands, if not millions, yet he still needs to wait for a 6-week license to practice in Nigeria. So such things, and moreover, perhaps it will even be more impactful for pharmaceutical companies who will probably need to get approval from all the 15 West African countries individually before being able to either have clinical trials or even roll out a product. Right. So it will be interesting to get that perspective. Thank you.
Any points of view from any of the panelists? We agree. I can take a stab at this. I mean, when these kind of things, I think there is two kinds of healthcare. I mean, one is the normal healthcare, which is your normal NCDs and communicable diseases, which are happening at a certain pace and the population is affected. And then there will always be these systemic things or sudden incidents that happen. My view is that and that's why I think healthcare can never be purely private in any country. I think the government has to have some oversight. We have to have some regulation for exactly these kind of events. I do believe when the Ebola thing happened, at least from a distance, what I observed was the regulations and everything were very conducive. I think frankly, the regulations all broke down, and everything broke down. People got into the act. Both the private sector and the public sector worked together, whatever they could. I think they were hugely unprepared. No amount of industry preparation can actually help in these kind of incidents. So I think this was a different case. It's not normal healthcare that we're talking about here. But I do think the regulation actually should be more around preparing for these kind of breakouts rather than actually kicking in when the breakout happens. Because when the breakout happens, actually regulation is the least of the issues. Because I think then human life is the most important thing, and that's what we saw here actually. That was my 2 cents on this. I don't know. Okay, we'll go. I'm sorry, I hope that answers your question as best as we could. Next question, please.
Okay, thank you. My name is Mark Achola. I'm based in East Africa. I work for AR Healthcare. We are 35 outpatient centers and one hospital, and I recognize the global players that I have in front of me. But one of the areas that I've not really had being addressed is that there's a lot of mobility of patients today, number one, and they all go to different facilities that you have because you're in more than one country. Now, the aspect of people delivering healthcare, which is our staff, to achieve what I call a consistently good service remains a very big challenge where cultures are concerned. But you have one brand which you make a promise. Now, I just want to get your perspectives in the challenges you have around addressing this, since it is something that I face, which I believe is similar to you.
If we can, may I?
Yeah, Malvinder, go first.
Oh, please, go on.
No, you go ahead. I'll answer after.
So,
No, it's okay.
So a quick answer from my side, also taking into account the time. I think that it's the duty of all health organizations to gradually move from individual medical knowledge to an institutional medical knowledge. That means that they should organize training, educations, and they should organize themselves in a way that they're going to build gradually their organizational medical knowledge, and then on top of the care standardization, you can ensure that you can provide a common medical outcome. We have such an approach in our organization, and I will use just one example from radiation oncology. Every week for 1 hour, you have Polish radiation oncology doctors, medical oncology doctors, the Bosnian ones, the Turkish ones, that they sit around a call and they discuss by themselves, and with Houston Methodists that we are associated, and they present what type of treatment they're going to give to a 12-year-old guy or gentleman or whatever with a sarcoma or whatever, and then the physicist is also presenting the type of treatment planning and so on. And on top of the training programs, and we have numerous, I think this creates a common understanding of how care should be delivered, and also it builds, what I said before, the institutionalized medical knowledge. And again, if you compare this practice to, let me use my country, where I come from, Greece, as an example, you have to rely to the knowledge of the certain medical oncologist and the right of the type of treatment he's going to give you. In our case, it's an open discussion, and you know our skills are developed through time, and you know you should expect a quite good result. But I agree with you, this is key in order to provide a good service over time.
I think really from our viewpoint, in many of the bigger cities in India where we have hospitals, between 25 and 35% of our revenues come from international tourists, from a medical value tourism perspective. And while the medical treatment is virtually the same, I think what we work towards is really towards an engagement model with the patient and the families in terms of connecting, communicating, making them comfortable in a foreign country, in a new space, in a new environment, and being able to address them in a language and to create an environment where they're comfortable. I think if we're able to address some of those non-medical issues continuously in a better manner, I think there would be a lot more medical tourism that would come into India, which has increased significantly over the last many years, and I see that increasing substantially over the next many years as well. So if you look at medical tourism, Singapore, Thailand, and India are the three biggest players, at least within Asia, and I see that increasing substantially over the next many years. So to me, it's not really the medical issue. The medical issue for every patient would be individualized and specific to their needs, but it's more the issue about giving them a comfort and creating an environment where they feel more comfortable.
Okay, and I guess we have the last two questions there.
Okay, my name is Ortman Siemens. I'm a private investor in this area. Used to be at IFC, and where one learns quite a bit. Anyway, what we have heard this afternoon is basically all of you seem to work in markets which have been disruptive. Eastern Europe basically was possible because the system collapsed and a new opportunity was given. I don't think that we can learn anything in the Western world, in the developed Western world, for whatever we have been talking this afternoon, except probably ethics, probably certain standards. And what Mr. Larsen was telling us is we have probably, the West has left a legacy in many of these countries in Latin America and probably even in Asia, where we have been given an impression medicine can only work if it is at a certain standard and level, which seems not to be true, because what we need is we have the doctors, we have the knowledge, we have the desire of the people to become healthy or stay healthy or at least get services. But our system, as we has built it up in the West, at least in Western Europe, does not provide for a new approach to medicine. Yeah? And I was wondering, how much are you working, for instance, with 8 institutions? About 8 institutions. Yeah? What I miss is that too many doctors and the medical profession in the West knows very little of what we are talking about here. And certainly nobody in the health ministries, because they are not involved in emerging markets business, also do not know anything about it. Yeah? And the 8 ministries, I come from Germany, BMZ, I mean, they are not doctors. The medical issue is wide away. They have good medical services. They have no interest, nor do they have a feeling for what is necessary. And so the question I have is, how much is your dialogue with the donor community, with the IFC we have here, with the World Bank we have here, and they are only in the infancy of this development, because they have missed the boat too for too long until they really were pushed to do something. Yeah? But how much is your dialogue, all of you, with those who are supposedly having the deep pockets besides Bill Gates, who are really able to do what Mr. Larsen was saying? We need help in developing new systems of delivering services. I'm thinking, for instance, I would like to have an IFC person here, which I don't see at the moment on the panel, is, for instance, a special fund which is fed by an IFC, which IFC is very creative, a special fund which is actually helping the governments of this world and the emerging markets to understand what is necessary in order to get the potential players into this system. And I think you, Mr. Larsen, have spoken very clearly on this. In Eastern Europe, I think the issue is settled and the players are there. But in many countries, Latin American countries and also Asian countries, and India probably will be the big push for change, but many governments, I just come back from Myanmar and see that they are totally lost in this new world, and how should they build up their systems? And I don't see any help coming from the donor community, because the donor community knows very little about this business. Thank you.
Right. No, it's a great question, although if I may comment that it was actually a better question for the previous panel. I think the previous panel talked about that PPP and how governments and how institutions can actually work together. I think the short answer that I got from that panel, and I can open it to everyone here, was that things have started. It's not great, but I think that somebody used the word that horse has left the stable or whatever. I think it's going to change. Things are going to get better. I think most of the governments get it. But, the governments, at least from an investor standpoint, I've always seen is always 2 steps forward and 1 step back. So things will be slower from the government side. But I think the private sector is definitely doing its bit to making the governments aware about it. And maybe one of you can comment on this. We're really out of time now, so just one comment, brief one, Dr. Chilappa.
I'll make a very brief comment about that. I think as an institution, Johns Hopkins, traditionally, I think we are helping on the, in tertiary care services and internationally. But in 2 countries, we are actually working to make some type of an impact and changes onto this. One is in India, where we are working with a group which is trying to do a primary health care, both on the private corporate side, and the stakeholder is also running a not-for-profit venture, which is on the primary care area, which is helpful in that area, which we think is going to help in modeling something, even which the government might pick up. In China, we are trying to help actually put up a system of research environment which would work on an academic area and which will benefit the elevation of the standards of what would be done in terms of, clinical research and other types of research. So I just wanted to give these two type of examples as an institution of what we are doing.
No, but it's a great question, and I think maybe we should probably interact with the IFC folks after the panel and actually debate this a little bit more. Last question for the panel, please. Thanks.
It's a long question for this time, but I would like to hear about how do you see the exit strategy, especially not on the short-term investments, but healthcare is a relatively long-term, and when you go global, there are lots, sometimes it spans over 10 and 15 years, and how do you see the exit mechanisms before entry from an investor perspective? And the second point is going global enough for a portfolio risk management and staying in the same industry or staying in a specific part of this industry, or you need to diversify also in the investment with other industries? Right. Can healthcare accommodate to one portfolio?
So I can take the exit standpoint, because I think these gentlemen probably are not thinking of exiting their businesses. Hopefully,
so it's the investor perspective,
and they can talk about the portfolio aspect. So from an exit standpoint, I think there are two main ones. First of all, I think the listed or the public play in the emerging markets, at least I'm talking about, is very, very little or very thin right now. If you want to do a healthcare investment, the publics don't provide too many opportunities. So there's obviously a great opportunity of, as the businesses become a certain scale, they will go IPO at some point. I see less of that happening. I think the bigger opportunity really is going to be what we call regional players buying out smaller businesses. And actually, that is their way of globalizing and actually building up bulk and getting scale and then dropping prices and improving quality. The other is there is an increasingly large amount of investor interest from private equity. So you actually find that the smaller PE funds are exiting after 5 years to a mid-sized PE fund, who then exits to a larger PE fund like a KKR or even a Temasek. You're also finding that a lot of long-term investors from sovereign wealth funds, I think they're very partial to healthcare increasingly, and they're willing to hold for 10, 15 years, and I think they're great partners from that standpoint. We also find we're a fund of funds, so we also have our own LPs in the US. Many of them are endowments, and they always have a soft corner for impact-oriented investments, especially in the healthcare space. So increasingly, they're also getting very excited about longer-term holds and direct deals in this space. So I think somebody mentioned that in the morning. I don't see money as ever being a problem or exit ever being a problem from good businesses, ever. I think that's never been an issue. I think the issue has been talent, how do you scale, how do you worry about disruption here, et cetera, et cetera.
I'll just add one comment. We had made investments in Asia, a series of them, and we spent close to $650 million, and within a period of 3 years, we exited them at $1 billion. We had good assets. There were many takers for it, and healthcare is a space, at least in the markets of Asia, where I understand it, there is a dearth of assets. So there are more buyers than there are sellers. So if you're making investments in healthcare in emerging markets, I don't believe you can go wrong.
The only thing I worry about this Uberization example is that Uber is still losing money. That's the only problem I worry about from an investor standpoint. But hopefully Uberization in healthcare will be different.
But I can tell you that will also start from emerging markets.
Okay, thanks a lot for your questions. Thanks for being a very patient audience. Thanks a lot to the panel. I think I didn't do too much to control you, so I think that was good. Thanks a lot.